This video is designed to help you learn how to interpret brain MRI effectively, courtesy of Dr. Pejma Marlani. In a previous video, we introduced the basic sequences in conventional brain MRI. In this video, we get a bit more granular. The focus here is introducing more nuanced anatomy on each sequence, which includes common blind spots and things to look for on each sequence. This includes many key pearls that you won't find in a textbook. It's important to note that the focus here should not be to memorize this information or use it as an exhaustive checklist when reporting every case, because that would be overwhelming. Instead, I want you to understand the principles and pearls introduced so you can get used to the normal appearance of this more nuanced anatomy. Once you become aware of the structures and their normal appearance on MRI, you will pick up on very important findings that you would have otherwise missed, including things like metastases in the skull base or mandible, important lesions in the neck, incidental aneurysms, etc. These are all findings that are not uncommon and do change management. As I've said before, the single best way to learn radiology is by reading real-life cases. But in real life, most cases don't have much learning value, so it takes years to get enough experience. In contrast, our Brain MRI course on navigatingradiology.com includes fully scrollable real-world cases, carefully selected to teach you the things you need to know, with a manageable case list that makes learning as efficient as possible. We gamify radiology by giving you AI-generated hints and feedback, interactive links to key findings, concise teaching points, and video answers for each case. To access this course or one of our many other courses covering topics like basic CT and subspecialty body MRI like prostate and rectal MR, go to navigatingradiology.com. So without further ado, I'll hand things off to Pejman, who will go through each sequence in more detail.
The first sequence is diffusion-weighted imaging. As you know, in diffusion-weighted imaging, we need at least 2 B values to calculate ADC maps. For example, here, this is usually the B0, and this is a B1000, and we need these ones to calculate the ADC maps, which is this. When looking at the high B value, commonly the B1000, I will make sure that I look at it twice. Once, I look at the brain parenchyma and anything that may show restricted diffusion in the brain, such as a stroke, hypercellular tumor, or hemorrhagic material. In the second run, I look at everything that is outside the brain parenchyma. From here to here, we have inner plate of the skull, diploic space, outer plate of the skull, subcutaneous fat, and skin. Essentially, nothing here should light up on diffusion-weighted imaging. This is very useful to pick up bone metastases or skin metastases. As we go further down, we will continue to look at the orbits, skull base, in particular the petrous bones here, and the clivus. Here, these are the basic occiput, these are the clivus, and this amount of signal is okay. That means this person has some marrow signal, but we do not want anything to light up. Sometimes it's not uncommon to see small suboccipital lymph nodes, such as these ones, or retropharyngeal lymph nodes, such as these ones, or intraparotid lymph nodes, such as these ones. But anything that lights up, we need to figure out what it is. Another important feature of diffusion-weighted imaging is that it is a non-flow sensitive sequence. For example, blood vessels which contain flowing blood should be signal void, meaning completely dark. In particular, I do check the expected location of the carotids, here, basilar MCAs, as well as the dural venous sinuses, transverse sinuses, and the suprasagittal sinus. If you see hypersignal on the diffusion weighted images, you should really look into it, as we don't want to miss a clot or possible mass. Another very important feature of diffusion weighted imaging is that it is a fat-sat sequence. The B0, which is this one, can essentially work as a poor quality T2 gradient echo sequence, but most importantly, with fast saturation. This is a very useful feature. Depending on the local practice and MRI protocol, dedicated fast-sat sequence may not be part of the routine brain MRI. This can be very useful to see if a T1 hyperintense lesion has fat or not. The next sequence is sagittal T1 weighted image. This acquisition may be different based on the local practices. Sometimes it can be a volumetric sequence, and sometimes it may be standard non-volumetric T1 spin echo or T1 flair. Nonetheless, I will try to follow the same routine, knowing that the images may look slightly different depending on the protocol. It is very important to know that the field of view of sagittal T1 weighted images extends far more inferiorly than the rest of the axial images of the brain. The axial images of the brain usually cover from here to here, but we see a large portion of the upper neck within the sagittal T1 weighted images, which we usually don't see on the standard brain images. And this is a very important point because we don't want to miss major pathology within these structures. For sagittal T1, we essentially do a parotid to parotid sweep. Let's see. This is the superficial lobe of the parotid gland. This is the deep lobe of the parotid gland. While checking the parotid, take a look at the lymph nodes. This is the sternocleidomastoid muscle. So these are the level 5B, and anything anterior to posterior margin of the sternocleidomastoid is level 2. You want to make sure we don't miss major pathologic adenopathy. Then as we go on, we check the bone marrow in the mandible. This is the mandible, and we expect to have T1 hyperintense bone marrow signal in the mandible. We can do it at a different sweep or when we do the parotid to parotid sweep. Depending on the field of view, we may have some or most or all of the mandible. This is a very great sequence to pick up metastases in the mandible. At the same time, I check the submandibular glands, which is this or this on the other side, if they are included in the field of view. Following this, I will check whatever I see from the cervical spine, essentially the vertebral body height and bone marrow. Make sure to pay special attention to occipital condyles, this one and this one, as they are common areas to miss metastases. Another very important feature on sagittal T1 weighted images is the petrous apex. A good landmark is the flow void of the petrous internal carotid artery. Then we know the bone posterior to this flow void is the petrous apex. Alternatively, if we can find the petrous apex, then we know the artery in front of it is the petrous ICA. This relationship is very useful when anatomy is distorted. Then we turn our attention to oral tongue, base of tongue, epiglottis, hard palate, and soft palate. I understand that this is not a dedicated MRI of the neck, but we should not miss major pathology or large masses within these structures. Then we turn our attention to midline structures, starting from the spinal cord, cervicomedullary junction, medulla, pons, midbrain, tectal plate, mammillary body. This is the hypothalamus. This is the pituitary infundibulum. This is the optic chiasm, corpus callosum, fornix, and cerebellum. Another structure that is great to get used to see on sagittal T1 weighted images is the hippocampus, as Most of routine brain MRI protocols may not have dedicated coronal images of the hippocampi. So this is essentially the hippocampus on sagittal T1 weighted image, the other hippocampus. This is the other hippocampus on sagittal T1 weighted image. The next sequence is pre-contrast T1 weighted image. Let me show you. Again, depending on the protocol, it can be a volumetric acquisition or a standard T1 spin echo non-volumetric. First, I would try to assess the bone marrow in the skull and the skull base. Again, let's take a look. This is the inner plate of the skull. This bright signal is the bone marrow in the diploic space. This is the outer plate of the skull. This is subcutaneous fat, and this is skin. This is, again, a perfect sequence to detect scalp or bone metastases. Same as in the skull base. This is the clivus. Very nice delineation of the clivus. And this is the petrous apex. I would usually try to take a look at the orbits on axial T1 weighted images, in particular the orbital fats and extraocular muscles. Is there no axial T1 weighted images? Then I would check orbits on sagittal T1 weighted images. Before looking at the brain, I force myself to check 5 pairs of fat containing structures on axial T1 weighted images. As we know, fat is bright on T1 weighted images. Lines and dots within these structures are okay as they're traversing vessels and nerves, but they should not be replaced with soft tissue. I learned this from Mary Scanlon from my fellowship. The first pair of fat is the inferior orbital fissure on either side. Let's take a look. This is the inferior orbital fissure on one side. This is the other inferior orbital fissure on the other side. See, T1 hyperintense fat signal. The second pair is the pterygopalatin fossa. Is here the right pterygopalatin fossa. This is the left pterygopalatin fossa. Again, the lines and dots are okay as there are vessels and nerves traversing, but these structures should not be replaced with soft tissue. The third pair is retromaxillary fat, this and this. And the fourth pair is the parapharyngeal fat, which is this fat and this fat. The parapharyngeal fat can actually be asymmetric when comparing right to the left side. But as I mentioned before, the important thing is it should not be replaced with soft tissue. Also, the parapharyngeal fats should not be displaced, as their displacement may indicate there might be a mass displacing them. The fifth pair is the fat underneath the stylomastoid foramen. This is the mastoid, this is the styloid process, and this is the fat underneath the stylomastoid foramen. And you may see 1 or 2 dots or lines within them, which can be facial nerve or stylomastoid vessels. This fat is very important, as the loss of this fat can be a very important sign of perineural spread of tumor or infection from parotid glands from here into the temporal bones. The next structure to look is the nasopharynx. This is the torus tubarius. This bump is the torus tubarius or cartilaginous end of the eustachian tube. This, the area behind it, here and here, is the lateral nasopharyngeal recess, and this and this are the opening of the eustachian tube. It is important to check for mass, especially in the lateral nasopharyngeal recesses, as most nasopharyngeal carcinomas arise from lateral nasopharyngeal recesses. Then we turn our attention to masticator muscles, the masseter, medial pterygoid, lateral pterygoid, and the temporalis muscle. The next sequence to look will be the axial flair. Axial flair is obviously a very important workforce of neuroradiology, other than pathology in the brain, such as tumor, stroke, edema, hemorrhage, midline shift, or hydrocephalus. I will make sure I check the following structures. I prefer to look at the pituitary infundibulum on flair. This should be midline and thin. If it's thickened or displaced, we need to figure out why. If our scan protocol does not include axial T2 weighted images, then I will check for flow voids in major arteries, such as internal carotid arteries, this one, this flow void, and this, the basilar artery, this flow void, and I quickly check for in proximal MCAs and ACAs to make sure I don't see any flare hyperintense signal within these vessels. I also check for flare hyperintensity in the dural venous sinuses. Sometimes we may see slight flare hyperintensity in transverse or sigmoid sinuses, which can be due to slow flow. Then we need to assess on other sequences to find out a reason. Sometimes we can find a small ipsilateral jugular foramen. Sometimes we may not be able to explain, and we may end up doing a CT or MR venogram to make sure we are not missing dural venous sinus thrombosis. Another very important structure to check on flare sequence or on axial T1 pre-contrast sequence are inner ear structures. Let me zoom in. These are not dedicated sequences to look at inner ear structures. You just see a hint of the cochlea, vestibule, and semicircular canals. On flare or T1 weighted images, the inner ear structures should not be hyperintense. If they are bright, then there's something going on and we need to figure it out. The next sequence I look for is axial T2. If this is included in my protocol, I would love to check the flow voids and axial T2 weighted images because they're much easier to see. So these are the flow voids of the carotids. They should be dark. This is the basilar artery. These are the MCAs. These are the A2 ACAs. And this is the junction of transverse sigmoid sinus. This is the left transverse sinus. And this is the right transverse sinus. In addition, although T2 weighted image is not an angiographic sequence, I would make an effort to make sure I'm not missing a big aneurysm at the basilar tip or carotid terminus, MCA bifurcation, or at ACOM. Again, I'm talking about big aneurysms. The next sequence would be gradient echo sequence, such as this, or susceptibility weighted images, such as this, which essentially either way or both, which essentially either way, what we need to do is to look for foci of susceptibility, which can represent hemorrhage or calcification. On susceptibility weighted imaging, there are ways to differentiate hemorrhage from calcification. And then we turn our attention and focus on post-contrast images. Again, depending on the institution and protocol, this may be performed as a standard non-volumetric T1 spin echo or a volumetric acquisition or both. Volumetric acquisitions can be a T1, can be spin echo based black blood sequences such as T1 space or gradient echo based white blood sequences such as T1 MP rage or even both. The main application of these post-contrast sequences is essentially to see if a lesion in question is enhancing or how it's enhancing or what the pattern of enhancement is. If T1 MP rage is part of the protocol, I actually prefer to check for aneurysms here. Again, I check here. This is the carotid terminus. I look at here. This is our basilar tip. These are here for MCA bifurcations and for ACOM. Again, I'm not talking about like a very teeny tiny aneurysm. I just want to make sure I'm not missing a large aneurysm. In addition, although we know this is a T1 weighted image and not a dedicated MR venogram, this is a great sequence to look at the dural venous sinuses. Look at this. This is the transverse sinus, sigmoid sinus, jugular bulb. This is the supraesophageal sinus. And essentially, this is an amazing sequence to pick up dural venous sinus thrombosis. Whether we have T1 space or T1 MP rage, I also like to look at post-contrast images on coronal reformats from front to back. First, I look at the orbits. knowing that this is not a dedicated orbit sequence and the fat is bright. But again, I try to make sure I don't see any masses or abnormality in the orbits. I will go further back and focus my attention on the cavernous sinus and the pituitary gland. Let me zoom in a little bit. This is a pituitary gland, and you can see we can beautifully see a 2 millimeter microadenoma in the pituitary in this patient, and we see the beautiful delineation of the cavernous sinuses on both sides. Going further back, we'll look at the internal auditory canals here and here to look for incidental schwannomas or leptomeningeal enhancement. I go further back. I'm at the region of the foramen magnum here, and we may find incidental meningiomas in this location. This concludes this presentation, and I hope you found it useful.